It's wonderful to have you here today for this timely and relevant talk, and one that is also co-hosted by the Center for Demography of Health and Aging. Rebecca Meyerson is actually going to be introducing today's speaker. And before I give the floor to her, I have two quick time-sensitive reminders to share. You've already heard them, but they're worth repeating. First, PAA. If you haven't already done so, please make your arrangements immediately. The early bird registration extends through the 15th of February, 1 week from today. A hybrid option is available. So again, if you haven't already, reach out to Mary Lynn and make your arrangements. Second, a plethora of opportunities continue to make their way into your inboxes. This will mark my last call for the methodology workshop on difference in differences with Scott Cunningham, to be held this Friday, February 11th. It's an all-day event and is co-sponsored by CDHA, among other centers. So that's it for the announcements. A very quick note on format for today's DemStem. Dr. Gurley is very happy to take your questions during her talk, so please chime in as questions emerge, or you can individually choose to hold them to the end. I will be monitoring the raise hands function and also the chat feature. So when I call on you, I will ask you to unmute yourself, ask your question, turn on your camera while you're asking your question if your environment permits. And I also invite you to have your camera on during the talk if your environment permits, so we can just hold a little more space together in this virtual context. If you're having any difficulties with these features, try to use the chat feature, type in your question, and I can relay the question on your behalf. That's it for formalities. At this point, Rebecca, I will turn it over to you to introduce our speaker today.
Hi, good afternoon, everyone. It's a great pleasure for me to introduce our speaker today, Dr. Tami Gurley, who is going to share her work on what I think is one of the key health topics of our day, mortality and health equity in the era of COVID-19. She conducts COVID-19 modeling and forecasting in her role as co-chair of the University of Kansas Executive Daily COVID-19 Digest Working Group, whose forecasts are used by leaders in public health, healthcare, and education. She will draw her data from the epicenter of COVID-19 deaths. Dr. Gurley is an economist and an associate professor at the Department of Public Health at the University of Kansas Medical Center. And she has published widely on key policies related to health and welfare, including the Earned Income Tax Credit, WIC, the health insurance marketplaces, and other elements of the Affordable Care Act, and studied how public policy and other factors shape breastfeeding, smoking at home, and child maltreatment, among other important health outcomes. Please join me in welcoming Dr. Gurley.
Hello, everyone. Please let me know if you have any trouble seeing slides or hearing me as we're going. I am so excited to be here today. And I apologize if it feels like I've been living under a rock and I finally got out to talk to people. There might be some truth to that. So I have essentially been detailed to what I would call decision support for almost 2 years now. And so at the medical center, what that looks like is basically taking my portfolio of externally funded research and moving that into the dean and chancellor's office. And so when they ask for something, I try to provide my best insights. And how did I end up in that role? Kind of by accident, kind of because I'm one of the only economists at the medical center. So when the deans started putting the team together, new dean, by the way, came in October of 2019 and then faces COVID in the School of Medicine, started putting just a group of people together. And I think we were supposed to review the literature and summarize the results. And so one of my colleagues she writes guidelines for the WHO and for all of the national organizations. She's a nephrologist by training, but really one of the most careful evidence-based medicine people I know. So I thought this will be easy. I'll join the group and work with Reem. And when we started working together, there was only one question at the time that people wanted to know the answer to, and that's how many beds do we need by June of 2020? What's the surge going to look like? The surge. More on that later. And so part of the reason I'm so excited to be here today is I feel like what has been missing from these very high functioning teams with very smart people and people. So they screen people for like altruism when they apply to medical school, right? And some people get through the cracks, but by and large, these are people who really care about society and making the world a better place. And so really caring people, very intelligent people, but almost all from the field of medicine. And what I think we've been missing is that broader perspective. And as the economist on the team, I feel very ineffective sometimes in kind of getting us to think about some of the broader messages. But as we go through this, part of what I've been struggling with kind of the entire time is we have all these policies, we're pulling levers. Are we changing outcomes? And one of my very early meetings with some retired FEMA disaster people who were supporting the city in their COVID response, Kansas City, mostly on the Missouri side, we're a little bit divided by state. The one thing that they said was, in pandemics, what we normally do is spread things out. We rarely change overall outcomes, which at the time was a very depressing thought, as we're trying to do lockdowns and masking and social distancing and then vaccinations. And so all through this time, that's largely what I've been struggling with. What are we accomplishing? What are we messaging to people? Are we hurting our credibility in the long term? What are the unintended consequences? And so all of these questions be swirling around, but I have a lot of data to show you today. All right, so as I said, when we first started this, the only question was how many beds, and I have some good stories about that, epic battles over the shape of the curve. My role in decision support largely at that time became forecasting, and so in forecasting, my thought is there are no style points. There are no points for causal identification. You only get kind of close or you kind of don't. And so that was my goal, was just to try to use the data to get as close as we could to what we thought was going to happen. All through this time, and I would say this continues, we've had trouble defining what our goal is, kind of from a policy perspective at every level, whether it's the school, whether it's the state, different people with different ideas about what it is we're trying to affect. I'm going to show you a little bit of data on policy effects of different measures. And then toward the end, we'll get where I think it's a place that I'm interested in looking at in terms of nursing homes. We've known for a long time that this is where a lot of the mortality is coming from. From a policy perspective, it's been very hard to focus on nursing homes and preventing spread there. I was in our first wave in the winter of 2020, 2021. I always felt like that we failed. We had 58 active clusters in long-term care facilities in Kansas at that time. And this winter, in our most current wave, we have 219 active clusters in long-term care facilities. So whatever we are achieving with our policy levers, we're not actually keeping it out of the long-term care facilities, which is where we're getting a lot of our mortality. So talk about some forecasting, and I'm going to go way back in time because I think to kind of get where we are today, it would be helpful to talk about where we started. So this was a briefing I gave to the governor of Kansas in April of 2020. This is when we were just trying to figure out what the world looked like. There are a gazillion different models out there, and most of them are really scary because whether they officially say so or not, they build in a lot of assumptions. They're mathematically beautiful, but they build in a lot of assumptions that lead to exponential growth, which, regardless of where you start, always gets scary. So we're talking to the governor of Kansas. Kansas locked down early, closed our schools and locked down early to bend the curve. And then we were this was a briefing about the economic impacts of the pandemic back when we thought it might be over in the summer of 2020. So we're talking about all these models, largely from EPI, that are just suggesting huge amounts of mortality and healthcare capacity problems. Now, we have reached those levels of mortality and healthcare utilization, but it has been over a much longer period of time. These models were predicting that we would surge and be done by July of 2020. I mean, I thought I would be back to my day job by July of 2020 based on these models. there was one model that said the peak was going to happen in it was an econ model. The peak was going to happen in June or July of 2021. And we just all laughed. We laughed because it was so far different than the other models. And yet here we are. All right, so we started, our approach was forecasting using a data-driven. So this isn't a model where we're building assumptions. This is just pulling the data. And so Kansas was not the first state in the US to have COVID. Several states, many, 15 states are ahead of us. And so basically what I started doing was tracking their data. And can we learn anything about where we're going based on where they are in a population weighted sense? So nothing fancy or highly technical here. And then started trying to fit the curve. Now, remember, this is the beginning, before we kind of knew what things looked like. Exponential curve did not fit the data at all. And so we were at the time using a parabolic curve. And the results that I got out of the data-driven model were far, far below the theoretical estimates from these exponential models. Why is that important? Our hospital was running a model, and I'll show you some of that data. I can't even fit it all on the same graph. They were running a model at the time out of the University of Pennsylvania. We spent hours talking about inputs, making sure they were all reasonable. All of the inputs were reasonable to this model, but it led to exponential growth predictions. And so our health system was planning on 5,000 beds in June of 2020. And my predictions were closer to 50. That will cause you some problems with the Secretary of KDHE. What are you doing? Those are two wildly different numbers. So let me put up some pictures. These are some of our earliest estimates from April of 2020. The orange line are my predictions based on other data from other states, population weighted. The blue line are these are cases, actual new cases. The silver line is the IHME University of Washington model, which was widely cited by the White House. So that's when we were tracking at the time. And you can see that IHME, even though not exponential, was predicting a lot higher cases than the actuals and then what my model was suggesting. But it did feel really risky at the time, because if it is going to take off on exponential growth, this could just be the slow start of an exponential curve, in which case I would be very wrong and feel very bad about that. But the thing that we knew at the time, and that I was talking to my colleague about, is we were watching data from everywhere in the world, and we just didn't see that growth pattern anywhere. So here's a fun one. This is from April 18th, 2020. So this yellow line is the line that our health system was using. So there are plans on the books to do a $12 million renovation of our new health education building, to turn it into a hospital so they could accommodate 5,000 beds at one time. This is the original IHME projection. They've made a lot of adjustments. It's kind of fun to watch them over time. And at this time, on the 16th of April, I finally became not the lowest prediction in the room. So IHME adjusted their numbers back down. That took a little pressure off. And then the orange line continues to be the estimates that I was making. And one thing that one of my colleagues kept pointing out is, you're spending so much time justifying why your estimates are so low, and they're still too high. And I was overestimating every single day. And this is the forecast of deaths. Personal opinion on the mortality data from the New York Times and some of the stuff that you could get publicly available, I would never use it in a daily sense. Maybe not even monthly. There's so much delay in reporting. We had 1,000 deaths hit the books all in one day from rural counties. So in terms of timing, it's just not accurate at all. So this is what I was talking about. We were watching curves from all over the world. So the US, Italy, we were tracking places that had really high cases early on. And again, the numbers are different, and on a per capita basis, they're different, but the shape of the curves were really consistent, right? We were going up and we're kind of plateauing. This is what it looked like in Kansas and Missouri. So Missouri is the orange, Kansas is the blue. And another thing about COVID data, it's so messy. We count cases, but cases depend on who's getting tested. And if your policy is when you get one positive in a long-term care facility to test everybody, or in a corrections facility, you're going to get a lot more cases. At that time in Lansing Prison, population tested everyone, and we had 80% asymptomatic. So if you're only testing symptomatic folks, you're going to pick up a lot less cases, and it's really hard to reconcile the data. And at that time, what was interesting is even though cases were different on a population weighted basis, the mortality in those two states looked very, very similar. All right, so here's one of the fun things, and I maybe not so fun when the governor is locking things down, stay-at-home orders, and what you say to them is, well, when we look at changes in mobility and how people are changing their behavior, the trends seem very similar. Sweden never did a lockdown order, so you see them kind of reduce their mobility, hold steady, and then when cases started getting bad there, again, they reduced their mobility by a lot. The blue line is Kansas, pretty much tracks the red line, which is the national average. So, what we were telling our governor is that we think that changes in mobility, you look at New York, this is when they were having that early surge in their mobility. They reduced their activity. This is retail and recreational activity. You don't see clear breaks when stay-at-home policies go into place. People were changing their behavior in response to something else. Media reports, if things got locally bad, then they adjusted their behavior more. And so, there's that study that came out from Johns Hopkins that stay-at-home orders, they estimated didn't change the course of the pandemic in those places very much. And that would have been our suspicion early on, because those orders weren't really correlated with changes in behavior. It was people were responding to something else in terms of their behavior. So way back then, we said it might be more of a plateau than a peak, a long race, not a sprint, not going to be over in June or July. And that because these patterns are so similar across states, across countries, that if there's any bending of the curve, and so I spent a lot of time with public health folks and the messaging, I don't think it bent, right? We may have shifted. And so part of my struggle is kind of the messaging that we send out and maintaining credibility over time through the pandemic. All right, so back then we were asking, can we please focus on the high-risk groups? Long-term care facilities, long-term care facilities, long-term care facilities. And then how is this going to affect long-run demand? And then the thing that I still struggle with is this idea that near and long-term effects of all of these policies may vary. And so I think we did actually slow the spread in March and April of 2020. But we have very little virus here then anyway. And I don't know, I'm going to show you pictures from places that did really, really, really good for like the first year. And then what happened after that. And so what I think from a cost benefit perspective, or when we think about these policies and the larger effects and the unintended consequences, is if what we're doing is changing timing, that's a different calculation than if we're actually changing mortality rates and trying to figure out what the right choices are along the way. All right, so ready to jump into some current data. That's okay with everybody. Fast forward to today. So we don't talk, I haven't heard the phrase exponential growth for a full 6 months, although that was a fight we had on a daily basis. So now we're pretty much resigned to waves. Are we on the front side, the back side, the trough, the peak? We think we're on our way back down right now, which is a much more comfortable place to be than on the way up. We're not talking about beds and ventilators anymore. So most places will say they can find beds, and ventilators weren't the most effective way we're better at treating COVID. And ventilators weren't the most effective way generally of treating it to start with. What we talk about is staff. So KU Health System had its highest number of COVID hospitalizations, I think about 3 weeks ago, 210, not 5,000, not 50, but 210, right? That was our peak hospitalizations, but at the same time, we had 1,000 staff out for COVID or testing. And so not only do you have the increase in demand, but you have the reduced capacity, and it's not beds that are the limiting factor, it's can you staff them? And this far into pandemic, people are tired. People are really tired, and they've been fighting this for a really long time. And so I think the healthcare workforce is just a huge area of concern for me, how we kind of maintain and protect our healthcare workforce. I think we're talking more about focusing resources, even the hardcore, we want to stem the spread. Colleagues of mine are kind of saying, okay, we're not going to contact trace. Why? Because A, there's too many cases and we can't. And B, people won't give us information anymore. People have stopped participating. And this is my big concern on the messaging and credibility front, is we lose policy levers when people stop kind of buying in. And I think they have some reasons to be concerned about some of the messaging that we've put out. And then I hope that we can broaden the discussion beyond virus outcomes. And early on, I remember, so I have 4 children, and the school's being closed. That was very personal. But watching my school district, which is in Johnson County, which is the highest income county in the state, versus the school district in Wyandotte County, which is the lowest income district in the state. We're neighbors, right? These counties are right next to each other. So you see what goes on in both. Johnson County got the kids back to school in roughly, the elementary school kids went back really early. The high school kids went back in the fall of 2020. And it's interesting how challenging it is to incorporate new information. We had very little evidence of spread in schools. So if your purpose was keeping kids out of school to stop spread in the school, we had very little evidence that was happening at the time anyway. But Wyandotte County is interesting in that their public health officers have a lot more influence, and they were very concerned about the spread. And so there's more underlying health conditions, more poverty in Wyandotte County. So there's lots of reasons to think that outcomes would be unfavorable, but they kept kids out of school essentially for the whole school year. So you take the county with already the highest dropout rates and some of the lowest test scores, and now you've kept them out. And I don't know what the long-term consequences are, but if we're not having a substantial effect on virus outcomes, then we really need to be talking about that and whether those policies are the right decisions or not. All right, so we're going to talk a bit about some of the potential goals, although I think many people have different goals in this process. One is spread, virus spread. Are we trying to control virus spread? Punchline on that one, I think the cat's out of the bag. We're done trying to control spread. Are we worried about hospitalization? Are we worried about healthcare capacity? There are clearly people still worried about that, particularly the hospitals. And they've had a little bit of trouble with messaging. I mean, they actually said, our healthcare system said the people that we have trouble communicating our capacity constraints with the most are actually the disaster preparedness folks, the FEMA folks, because they've seen our plans to have 5,000 beds at one time, right? Like our short-term emergency capacity is different than our day-to-day, we can sustain our business model kind of capacity. And so those things got kind of confused over time. We'll talk about mortality from COVID, but then from all causes. And that's why I really think we need interdisciplinary minds at the table, because we focus on COVID so specifically that there are so many other things going on. I think about child maltreatment. I think about preterm births. I think about mental health. There's so many things that could potentially be going on. I hear less talk about equity. I wish we were talking more about equity, but I do hear less talk about that. And then cost per death avoided. I'm probably not going to write this paper. Wish somebody would do a careful analysis of this. My kind of working hypothesis is that this is going to be COVID measures are going to be some of the most massively expensive ways to prevent a death that we've ever undertaken, compared to Medicaid expansion, compared to all sorts of other public health policies that we could imagine. All right, so somebody mentioned something about differences or a seminar a little bit earlier. So I want to put this chart up. This is actually from some published work. This is the red line is non-mask counties. Read rural Kansas counties. The blue line are mask counties. Read urban counties in the Kansas City and Wichita metro area. And so the study is to assess the differences in cases in mask versus non-mask counties. And I've put the full picture up here, but the part of it that's published ends right here. So this bit is what was used to establish the parallel trends assumption. This bit, right, and the two red lines, first red line is when the mask mandate went into effect, and the second red line is when they think it should have started affecting cases. And so you see that story lines up pretty well, actually, if you take it from this point forward, and it looks like, yes, the mask counties were successful in curbing some of the spread. If you look back in time, though, this is a difference in difference nightmare. Right? I would say this is the time when you don't want to use differences in differences. So what's going on here? This red line, these are non-metro counties. These are our counties with food processing plants: Ford, Finney, Seward, Crawford, think meat processing plants, where you have hundreds of cases, thousands of cases. We see spikes, and then essentially it goes dormant for a while. And we see this a lot as it percolates through the community. And then we see spikes again when it starts popping up in our corrections facilities and our long-term care facilities, where we test a lot of people. And so is this the effects of masks, or is this just kind of the waves of the virus coming and going? And it hit early in these counties with the high food processing industries. So where are we now in new cases? This is US data. I just want to point out that we're about 2.5 times in cases, 7-day average, than we were last winter. If I put that into an intent to treat model with natural immunity and vaccines, I'm going to be very, very disappointed with the direction of that estimate. How do things look in Vermont? I picked Vermont because Vermont's our most vaccinated state. And by all accounts, they did things right. They really locked down. They kept their cases really, really low. They got highly vaccinated. They're, I don't know, 76% vaccinated in Vermont. And that's not even accounting for the 5 and under population. They have seen a peak this winter that's orders of magnitude. I'm not even gonna put up Australia's picture. There's even more crazy. So our most vaccinated, it clearly didn't stop the spread. We ran ads for 6 months in Kansas that essentially said, get vaccinated so you don't get COVID. And so the danger of connecting the dots out further than they need to be. There was so much focus on the time about throwing every incentive you can at people to get them vaccinated. So tell vaccinated people they don't have to quarantine. Yikes, it seems like vaccinated people can spread it pretty effectively. If we have a big event and require vaccination, what are we accomplishing with that? Other than trying to provide an incentive to get vaccinated to go to the event. It might protect the person, but it's not stemming the spread. And so going back to what is the goal? What are we accomplishing with these measures? This is Canada. I picked Canada because they're 81% vaccinated and they're close to us, right? But similar thing, we've seen a huge explosion in cases. The patterns look really similar. They look really similar across places. This is I have to put up Kansas data. So this is where we are now. This is our black line is our 7-day average. The orange is the forecast, which is a little troubling. Now, still we're running this on states that are further into COVID than us. And I don't know if that makes any sense at all now. So I think of this as kind of an average, population weighted average. The difference between this national picture, which is showing the clear decline, and this forecasting picture, which shows a little bit of trouble maybe out there, or at least we shouldn't celebrate too soon, is that the national data is completely driven by population centers. California, Texas, Florida, the highly populated states, right? They're just so massive compared to Kansas that has 3 million people that we can be kind of having a crazy experience in Kansas and it not move the national numbers at all. This forecast basically gives each state 1 vote. So Wyoming is the same observation as New York, as California. And so when we do that population weighted by state, we get a slightly different story, that there are still places out there with really high per capita COVID cases. Wastewater. Spend a lot of time talking about sewer water now. And that actually is a bright point, right? So we're seeing clear declines in the amount of COVID that's being picked up in the sewer water. The dark blue line is the US, the salmon colored line is the Midwest. And you see that by and large, not exactly, but by and large, the cases kind of track with these, the cases are the very faint lines, kind of track with the sewer water. Now, sewer water is coming down a lot faster than cases in this chart. But one thing that is true of the wastewater data is it's never current, right? It's like always a week or something behind. But the hard thing is it's true in aggregate, but the local data are not so clear. So this is Douglas County. This is where the main campus of the University of Kansas is. And wastewater testing data, we've basically been increasing since summer and are still at some of our highest levels, even though cases are coming down. But look at this statistically. If I was running a relationship between this wastewater data and these case totals, I'm pretty sure I'm going to fail to find a relationship there. And part of what I think is going on, especially during the school year, is testing avoidance. So we get a lot of COVID, but and I'm going to show you some pictures from the college campus. In that population, when you've got people age 18 to 24-ish, you have a lot of asymptomatic cases or cases that are mildly symptomatic enough that I'm not sure if it's allergies or COVID or just a bad night, right? And also we had a lot of testing avoidance. So people learn that if they test positive and you shut down their whole Greek house for 2 weeks, I'm not going to get tested where you're going to find out. I may get tested at home or in the neighboring county, but you're not going to know. And so I think a lot of this high levels of activity, even though we had low levels of cases, are just kind of specific to the university population. This is hospitalization data nationally. So our cases are about 2.5 times what they were last winter. If vaccinations reduced our hospitalizations by 90%, which is what my chief medical officer would like to say. Only 10% of our, I'm not sure. COVID data are messy, but it didn't, right? We don't have 2.5 times the hospitalizations, but we had our highest level of hospitalizations this last winter. Our most vaccinated groups are these first two here, 70 plus and 60 to 69. They're more than 90% vaccinated. They're still leading the charge in terms of hospitalizations from COVID. And although there are clearly more children who have been hospitalized, that is true. It is not a child's disease. We are still having the heavy impacts, the most severe impacts among the older populations. This is Kansas hospitalization data. Looks a little different, kind of sticky out here. We've been holding pretty steady since December of 2021. And so in terms of it's residents, this is residence based, not necessarily. So since we sit on the Missouri border, some of our influx could be from Missouri residents, and that's not picked up in this Kansas data. But also our health system would say, we think some of this is just capacity constraints. We're not taking transfers. We're not taking transfers into the hospital, and so they remain at their long-term care facility or they remain at home. And one thing I'd love to throw out to this group and get some thoughts on is the conversations that we have, and should we have them? And one of our VPs at the health system said, I'm having these conversations, this is last winter, that I've never had to have before. Someone calls me from a long-term care facility and says, I have a transfer. And I say to them, is it going to escalate to the ICU? And so if there are advanced care directives that say it's not going to escalate to the ICU, I can't take them. I'm not going to take them. I don't have capacity to take them. And so how that changed our particular dynamics in terms of outcomes. Way back in the day, in September of 2020, these slides could have made you popular with the local journalists. This is modeling what's going on at the Lawrence campus. We never publicly released this model. There was a lot of chatter, and I'm kind of glad I was getting a lot of media training in case we decided to publicly release these data. But I just want to show you, because we talk about age groups, and So what I'm trying to convince you of is if we really want to affect mortality outcomes, we have to look at long-term care. We have to look at older populations. So this is the model predicting COVID-19 student positives on the KU Lawrence campus. We've got 20,000 students coming back to campus. And this is the actual data from Entry, Surveillance, and Watkins, which is our student health center. Oh, by the way, how do you model what's going to go on at the Lawrence campus? I don't know. There are some people who live in Greek houses, some people who live in dorms. The only data I had on people who live in close proximity and COVID spread and testing was from Lansing Prison. So most of what you're seeing is modeled after growth rates that we saw in Lansing Prison. Don't think it was terribly far off in the end. Okay, and this is Douglas County. So that was another concern. You know, at the time we're bringing college students back to Douglas County, are we having a big negative impact on the population that lives in Douglas County? So we're tracking both. I'm going to fast forward to the results, change the title slide. Got bored with the other one, I guess. So where did we end up? In the end, cases, now these are calculated cases because we were adjusting for non-testing and we're adjusting for asymptomatic cases. We had some early data on asymptomatic cases based on people who were coming back to the dorms. We tested all of them. And so we knew how many positives were asymptomatic. We had some early evidence on testing avoidance. We had a widespread randomized sample of testing in the first week. And we know how frequent people tested positive from Greek houses and the dorms and all of that. And then the second week, guess what? Behavior really changed. And we had a lot of people not showing up for testing. And so we had some idea about what avoidance might look like. So we're adjusting for those two things, but we think that cases, we think we got about 6,300 positive cases that fall. That was 21% higher than our model predictions. We think Douglas County cases were higher, about 40% higher, but look at hospitalizations. My model based on the prison data was predicting 14 hospitalizations, and we had 3 in the student population. So those were a good bit lower, even though cases were higher. And then Douglas County residents, hospitalizations were 11% higher, but cases were 40% higher than predictions. This is what the pictures look like. And what you see, this uptick here in cases, by the way, the blue is the actual confirmed positive cases that we have on the books. The green is where we think we were. This uptick is when kind of everybody started that wave in the winter. And then this is what we think happened in Douglas County, that things were really close to the predictions until yet again, that wave started in the winter of 2020 and kind of everywhere at the same time. And I'm going to switch gears a little bit. So that's what we think went on in the broad population in Douglas County and what we think went on campus. One of my colleagues put this together early. We knew all of this stuff early. And I think that's what's so painful about it, that we didn't do anything to really change outcomes in the high-risk populations. So this is cases by age category. We see a lot of cases in the younger age groups. I think there's just a lot of asymptomatics in the 0 to 17. I bet I've seen how daycares operate. I know how my 4-year-old operates. They've had positives. And then case burden for as people get older. But then we look at case fatality, who is dying from COVID. So who's getting COVID, who's dying from COVID, and then he calculated the fatality burden. And it just increases rapidly with age. I'm going to show you similar data in a different table, sorry. And so this is percent of population to date that we've lost from COVID in these age groups. We've lost almost 4% of our population, 85 plus, to COVID. 1.5% of our 75 to 84, almost 1% of our 65 to 74. So if I'm going to change mortality outcomes from COVID, I'm going to focus here. I'm going to focus where we're getting the heavy burden, which is interesting because all of our mitigation policies were shutting down schools, daycares, travel, bars. I don't worry about bars. But those were so we were trying to stop the spread, but it wasn't effective. It wasn't effective of keeping it out of long-term care. This is data from our clusters. So a third of our deaths come from clusters, and over 90% of those come from long-term care. So about 12% of cases in long-term care are reported as a death eventually. This is where we are now. We've got clusters in these other places, but you almost never get the severe outcomes. So again, I don't worry about colleges, daycares, schools, travel, the places that it was popular to shut down. I worry a lot about long-term care. We have 219 clusters with 4,200 cases. And on average, to date, we've hospitalized 18% of those, 12% of those. So note that we have higher mortality than hospitalizations out of long-term care. And I think that has something to do with our transfer protocols and something to do with advanced care directives. Healthcare facilities are largely rehab facilities, so step-down facilities after you've had a heart surgery or something. And then group living is just what it sounds like. All right, so now I'm going to actually talk about data analysis and not so much about forecasting. So my question is, are we changing outcomes, and how? I have struggled so much watching the data because our health system, we it's all vaccinations. We need to get people vaccinated. But if those vaccines are not as effective for the people who are most vulnerable, we're not going to change outcomes to the degree we said we were. And that's the data inconsistency that I have trouble with. And our CMO will say, well, you look at the person who's in the hospital who's vaccinated and you say, oh, well, it didn't work very well for you. You were already immunocompromised. And I say, those are the people we have to help. If it doesn't help those people, then how are we going to move outcomes? So some evidence, but most of the evidence from the literature is associations, and most of it's really early. Most of it's 2020 data. And so I think for us, when I look at the cluster data, I think of long-term care as a lagging indicator. So I think of spread in schools and daycares as a leading indicator. We had an outbreak in our daycare, 6 kids, all of them asymptomatic. Guarantee if you would have tested everybody, you would have found other cases, but they just go undetected because they're not terribly symptomatic. So it's not those cases that are problematic. It's not necessarily their parents or their aunts and uncles. It's when it gets to when it filters into the older populations. Religious gatherings tend to be problematic, long-term care facilities, places where you have gatherings of people with high risk. There is some association between nursing home quality and deaths, although I wonder how much of that is actually where the nursing homes are located and the socio-demographic information of those places. Nursing home size has been associated with more size, more crowding has been associated with more deaths. There's a lot higher mortality just in general in places with higher percentages of racial minorities. And then there was this early paper that looked at cell phone data, millions of cell phone records, looking at staff mobility and how that affected spread of COVID, largely in the New York area, I think. So they found that having more of your staff working in different locations led to more spread, which is not terribly shocking. And we had some reports from interviews that in Kansas, a long-term care worker showed up to work. She's symptomatic, she has a fever, and she's told you either need to work or you won't get paid. Right. And so it's easy to see how it gets into the facility. Nobody really has a choice in that instance. So I'm going to pull nursing home data. This is facility level data, national data and I'm only using 2021 to 2022 because there's a lot of data concerns with the 2020 data, although I'll probably go back and pick up the last couple months of that. From the CDC, get information on positives, hospitalizations, deaths, staff positives, staffing shortages, reinfections, vaccine, but there's a lot of missing values in some of those variables, so don't get too excited. But there is a lot of information. So far, I've merged on the Google mobility data by county, just because Google is easier to deal with than Apple, but I will eventually merge the Apple stuff in there too. And that is percent change from baseline for different categories. And then I've got COVID cases and deaths by county. That's the New York Times data that you can get out of GitHub. So it's all publicly available data. How many facilities? We've got 15,253 facilities with non-missing data in I think that's in case reporting. 15,051 of them are in there for all 55 time periods. So we do have a lot of consistency across the facilities, and that's the set of facilities that I've kept so far and the results that I've run. I'm going to use the facility fixed effect because I really can't think of another way to address all of the other things that I would need to control for. So there's facility stuff like management practices, but there's local area stuff like which industries are there, how many transportation corridors do you have, what are the underlying demographic, socio-demographic characteristics of your county. And then I put some controls in the model, and I have a weak fixed effect because we have such strong correlation between trends across places. So just a quick look at means. These are means across all facilities. So resident cases around 55 on average. I think, yeah, these are the current means from the current time period. Hospitalizations about 25, deaths about 10. That's deaths from COVID. Deaths from all causes are 45. So the deaths from all causes swamp the deaths from COVID. And I think that's something else we need to talk about is if we're completely focused on preventing COVID deaths and we cause a substantial number more of isolation deaths or just general decline deaths, where does our balance need to be? And then staff cases are about equal to resident cases. That's true in the total data. So this is total across both years. Patterns look really similar. But to give you an idea of magnitude, we're talking about 150,000 deaths, which is 16% of the US reported COVID deaths. All right, so I'm going to present some outcomes by vaccination status. I've just divided into high or low, basically divide it in the middle. High is 80% vaccinated or more, low is under that. So hospitalizations are higher in the low vaccination. And these are true of the current data too. So I'm just presenting the totals from the pandemic, which suggests that the patterns are the same whether you look overall or whether you look in the most recent period. So whether it's going to be a vaccination story or something else is driving results, it's going to be an interesting question. Cases were higher in our low vaccination places. All-cause deaths were lower, and this has been picked up in the literature before, that we actually, so I think we've got to keep an eye on both of those outcomes. And then staff cases slightly lower in the low vaccination places. Is that really lower cases, or is that just lower testing and lower reporting overall? You see, I'm quite confident in the data of measuring exactly what we say it's measuring. So I'm just going to put up some regression results because I know that I want to leave time for questions. So an additional occupied bed, so a bigger facility, then we get about a 1.5% increase in mean level new admissions, and the mean being 0.22 per week. An additional vaccination within that facility decreases it by about 1%. Cases in the county, so this is 100 cases in the county, a slight increase, but what I will say about this is everything is contemporaneous right now, and I think county cases, if long-term care is a lagging indicator, I need to look at county cases from 2 weeks prior or 3 weeks prior. We think the lag actually is 3 to 5 weeks as those cases go from the heavy spreaders, which could be daycares or could be indoor concerts or Lake of the Ozarks or any number of things. It goes from heavy spreaders, works its way to the community, gets to corrections and long-term care facilities. You know, and this is consistent with the literature, actually, that the biggest increase in the percentage-wise in the predicted hospitalization is from a new staff case. And that could be higher than a new resident case because not all staff cases are picked up, right? There is a lot of testing avoidance going on. So when someone is actually symptomatic enough to get tested, then we've clearly got something going on in that facility that's going to lead to hospitalizations. And then this is a new resident case, increases the predicted number of hospitalizations. I'm going to add in some extra control variables. So work mobility, so more people driving to work, we see lower cases, and that could be because if you're going to work, you're not gathering in small groups where people don't distance or wear masks. Increase in retail mobility increases the probability A staff shortage reduces the predictive hospitalization, and that seems counterintuitive. And so I think that's something worth investigating a little bit further. One thought here, though, is to transfer someone out of long-term care to a hospital requires a call. And sometimes it requires a lot of calls. And sometimes it requires a lot of calls to a lot of different states to find a place where that you can send someone. And so I wonder how much of this is really about staff shortage and how much of it is just we can't make those calls. We can't make those calls to transfer the resident out. And then all of the other results basically remain the same. I think, yeah, that's all of the data that I brought today.
Wonderful. Thank you so much, Dr. Gurley. This is a very provoking talk. I will facilitate the questions. One did come through and requested that we wait until the Q&A to relay it. So I'll go ahead and kick off the discussion here. This is coming from Malia Jones. It's striking how much different this story looks in hindsight compared to how it was unfolding in the moment. When you were making those April 2020 estimates, the best data we had was coming off the Diamond Princess, and no one could get a test, so we truly had no idea how much community spread there was. There was also no way to protect the most vulnerable. So, what are your big takeaways for modeling in the next pandemic?
Boy, I think it's
an easy question.
Yeah. I think it's flexibility. And what we were doing, like, because you bring up the cruise ship data, and we were grabbing bits of data from everywhere, whether it was the prison testing. There was a private school here in Kansas City that population tested their school on a regular basis. So we had an idea that the underlying positivity rate and we had pre-operation testing from us and from Children's Mercy Hospital. So we had about 1% positive. Our population testing positive for COVID, whether it was like bringing the dorm folks back and testing them all, anytime we had anything close to random testing of the population, we got 1% or less positives. And so we did have some indication that we weren't seeing skyrocketing levels of COVID in the community. But we were getting wild variations in testing, or in cases, exactly what you're talking about, testing, right? There are people who came back. I know of a pediatrician who came back from New York early in the pandemic, was heavily symptomatic, called his doctor, and she said, there's really nothing we can do, you should stick it out at home, right? And so that case was never counted. And there's so much messiness. And I think that's what we have to do. Someone from the Kaufman Foundation said one time that lack of published results doesn't mean lack of evidence. And so I think that that's what we're trying to do in the pandemic, is just pull every little single data point we can and add them together. But that flexibility and interdisciplinary groups, I certainly hope we can bring more people to the decision-making table next time.
Great, wonderful. I have a related question, and it has to do with this theme of uncertainty in the data. You mentioned your confidence in some of these data sources, and even as you were describing, well, as you were responding to Malia's question, that came up again. And then also in your talk, you mentioned media training. And so one of the questions I have for you has to do with how you address the uncertainty, really, like as you're talking to policymakers and the public, but you're sitting down with the governor, making recommendations, completely aware of the depths of uncertainty in your data. So how do you do that?
Well, luckily, economics training gives you a lot of squishy words. I think, part of it is like putting bounds around that uncertainty too. And I had a local reporter, and mask mandates, some places had them, some places don't. It's a big fight here. There are lawsuits. It's a big fight. People with strong opinions, whether I think it's doing anything for us or not. And I see all those resources and all that time going to fighting over it, but being really clear about what you're saying and what you're not saying. So what I'm not saying is I'm not saying that masks aren't effective. We've seen them be effective in healthcare settings. We know it stops the spread. We see very little transmission between providers and patients. You take those same people and you put them in the break room, crazy COVID spread, and they know how to use masks. So mask being effective is different than mask mandates being effective, right? And separating we're talking about science, but then there's behavior and there's how people respond, and being clear about those differences, but being honest. And that's where I think we in Kansas have failed a little bit. Our messaging that getting the vaccine means you don't get COVID. A lot of people have experienced that personally now and know that that's not true. Saying getting the vaccine means you won't go into the hospital. Again, not true. Does it reduce the probability? Yes. And so being very careful. One of my public health colleagues early on, this is when we thought we could stem the spread and be done with it all, right? Said, I heard him say out loud in our meeting, I don't care what I have to tell them. I need them to do what I need them to do. And that kind of focus on the short term when you have these repeated games and not being honest about the uncertainty. And I don't know, I am not good at messaging or marketing or any of that, but not acknowledging the uncertainty, I think, leads you open to criticism down the road when it becomes clear that you really didn't have all the answers.
Thank you. I appreciate that. We have a few hands up in the queue here. Rebecca, go ahead and unmute yourself and ask your question. Your sound is not coming through, Rebecca.
Oh, pardon me. Hope it works out.
Yes.
Okay. Thank you for a very interesting talk. I was wondering about your experiences with, coordinating or not coordinating with Missouri, being right on the border, or were there any interesting cases where, part of Kansas City is locked down because it's in Missouri and part of it is not, or the policies were wildly different? Any comments on that front?
Yeah, we saw all of that. And that made it hard for our public health officers who were convinced that you had to maintain the mask mandates and the shutdowns because you have the neighboring city with the same pattern that doesn't, and unfortunately being right on the border. So I would say the biggest collaboration I've had has been with MARC, Mid-America Regional Council, and they operate a lot of our services, especially on the Missouri side of Kansas City. But it was because they reached out to me in particular, and we kind of coordinated on what we were doing. So it has been tricky and in some ways a bit competitive instead of sharing information.
Interesting, thanks.
Thank you. Eva, go ahead and unmute yourself and ask away.
My question actually is also along the lines of the early projections that were made about COVID. And can you please comment on the pros and cons of making projections to a point where you're just not certain about what's going to happen? And in retrospect, do you think the pros outweighed the cons of those projections? Because I can see, for example, wanting to make a projection about what's going to happen so that you can direct resources to extra beds. But what if that's actually, you've just directed your limited resources to something that might not help, and because you didn't have that information. So I guess in retrospect, do you think it's beneficial to make those sorts of assumptions, or should you just cut off those projections at a certain point and say, well, we just don't know?
I think you have to do both, and it kind of depends on what audience you're talking to. The healthcare system had to make real-time decisions. Now, because their models were so aggressive, they scared people. They really scared people. They were calling people who hadn't practiced medicine for 30 years and telling them they were going to be pressed back into service, right? And so the amount of fear that was going around our community was probably more than what was warranted. Not because COVID hasn't been as severe as they said it was going to be severe, but it just wasn't as time sensitive. And so I think you're kind of in this unfortunate situation where you have to make real decisions and you have to prepare as best you can. And so Lee Norman, the secretary of KDHE at the time, would say it's about balancing risk. We're trying to balance risk. Now, whether we share those wild projections that are clearly different than the current data with a wide audience at, say, our weekly media event, I think that's a different story.
Thanks.
Jason, go ahead and unmute yourself and ask your question.
Hi, thanks for the talk. It was really interesting. So you talked a lot about this relationship between like social behavior, messaging, and the spread of COVID. And I think another area that I've thought about this, it's not something I study at all, but obviously, like everyone, I think about it a lot. Is sort of related to variants and vaccine efficacy and the contagiousness of these variants. And it's like the initial trials of Pfizer and Moderna had it in the 90% efficacy range, and which was unheard of for flu vaccines at the time. But later, during the Delta wave and Omicron waves, the efficacy was lower in the 50% or even lower range. And so many interpreted this as like due to Delta or Omicron being more contagious. And so I was just wondering if you could talk a little bit about like, what does contagious mean in the absence of social conditions? Because obviously, the conditions of masking and staying at home orders were very different during the initial trials than they were during the Delta wave and the Omicron wave. And in particular, like, what does this mean for how we should interpret or message around vaccines in future pandemics or even just future COVID vaccines that come out?
Yeah, that's a great question, of course. Well, and who volunteered for the vaccine trials? And I think, my oldest son and I used to walk through the grocery store and we would look at the people wearing masks and we're like, they're vaccinated. And the people not wearing masks were like, they're not vaccinated, right? Like they're kind of revealing their overall preference. At least that was our story. That was our theory. And also like the vaccine trials didn't include our highest risk groups, and so when just personally, my parents live in Eastern Colorado. That is one of the most socially isolated places in the country. And then they would get bored and go to Walmart in Finney County, where we have all of our food processing outbreaks. Good job. But these behavior changes are fascinating because you look at places like Vermont and Australia, and it's like they locked down, they got vaccinated, and then they went back. Like you had all of this pent up social demand. And so how much of that can you contribute to the vaccines? How much of that is change in behavior? And will we ever sort it out? I don't know.
Thanks.
Thank you. Michal, go ahead and unmute yourself and ask your question.
Thanks. So first, just thanks so much for a great talk, Tammy. I want to especially say that I appreciate how clearly you articulated the tension. Like, I feel like oftentimes in these discussions, we feel like, everyone just wants to follow the science, right? and do the right thing. But the problem is that the science doesn't speak for itself, and we have to figure out what questions we're asking this. And I really appreciate your sort of constantly coming back down to like, what's really the goal, right? Like, which population are we really trying to intervene on? The answers might be different if we're talking about cases or hospitalizations or mortality. And that's really, really important, and that doesn't get enough emphasis. So I really appreciate the centrality that you gave that in your talk. And the question I have for you is sort of on the latter part, on the nursing home results that you showed us in the end, right? So as with so many things, the pandemic brought attention to problems that were there long before the pandemic, right? The things that prior to the pandemic, it was easier to ignore, and the pandemic made it harder. And like the vulnerability both of nursing home residents and, as you also showed us, of nursing home employees, right, of the staff that are incredibly precarious, usually very low paid, have to work in multiple facilities often in order to make ends meet because the one facility doesn't pay them enough, is a major part of the story. And the sort of low standards in nursing homes is not a new story, right? It's something that has been going on for decades prior to the pandemic, and if not before. So I wonder if you are seeing any kind of change or impetus in the way in which the pandemic has really centered the vulnerability of the nursing home population, if you're seeing any change that's being motivated by that at all.
I think that's my biggest disappointment through this all, is that we really haven't been able to change the conversation there or the focus there. I remember early on, Reem and I put in a grant that wasn't even scored, I think, to do different testing strategies in long-term care facilities, right? To see, and there just wasn't, I mean, not that there hasn't been some work done in long-term care, but it was hard to get the conversation focused there. We wanted to talk about schools and travel and bars. Bars are easy to talk about. And it was really hard. And I remember one of my colleagues who does occupational health and nursing facilities, and she's like, yeah, you can't touch it, right? There's too many politics behind actually. And at the time I'm like, why? We shut down schools. I never thought that would happen. Like, how can we not? And so I think we need to go there, and we haven't. I don't think we've been successful in getting there.
Thanks. Malia, before your question, there's one that came through in the chat from Akarshik Banerjee. My apologies. Thank you for your grace there. And the question has to do more with the different data sources or the factors that you're considering. Can you tell us if you considered using rise in consumption of vitamin capsules or fever reduction medicine to enhance the prediction of COVID infection cases? Because many people do not truthfully report if they are infected. And this question reminded me of that example you gave about the friend who had traveled, clearly symptomatic, was directed to just stay at home. So how are these other behaviors, how are you considering them in your modeling? Or can you?
Yeah, so if you want to see all kinds of adjustments based on different potential behaviors, IHME is the model that probably does the most of that. And they've really been trying to explain outcomes based on changes in behavior and changes in policy. It's hard. What I have been doing is really just following the data. So all of that stuff is just baked in there in terms of cases and deaths. But then you've got all of the other things going on, like who's testing, when are they being tested? But no, I think these creative ideas, and so that's kind of where the wastewater comes in. That's kind of where we are now. How are we going to know where cases are? Because Kansas isn't contact tracing anymore. People won't respond to the questions. And so, some of these, we're moving past some of these things that we thought were giving us information, and people are focusing more on the wastewater. But I think these creative ideas about, we need more ideas. We need more creativity beyond the traditional clinical viewpoint and the traditional epi viewpoints. And so if you're interested in participating in the data or the literature, I would encourage you to do so because it's much needed.
Great, thank you. Malia, go ahead and unmute yourself and ask your question.
Hi, thank you. I've got another really easy one for you. My apologies in advance. So I'm a little bit struggling to reconcile your call for equity at the top and more focus on equity. And then later in your talks, I appreciate the need to focus on our most vulnerable populations, but I find it a little disturbing that we don't worry about cases in kids when a lot of our most vulnerable kids actually live with their very vulnerable grandparents. And that we see that that's the most common household that's disproportionately the household type for Black families whose parents are incarcerated. So I'm just wondering how you think about that in terms of this cost-benefit equation.
Yeah, I think those are exactly the kind of issues that we need to bring to the table, which is part of why I was so excited about coming here today. I think from a public health perspective, we have the public health officers of our biggest counties on the task forces. And everything is from a clinical perspective. And from a clinical perspective, we are seeing more kids, but these other outcomes that the kids live with elderly grandparents, that affects a whole number of outcomes outside of just your COVID outcomes. Those kinds of things. And there's been strong resistance, and public health is mental health. It is preterm birth. It is, some of these other things that we're talking about. But It was fascinating in the COVID discussion. It very quickly only became about COVID spread. And that was the only thing we were talking about. Now, in these households, COVID's a big deal, right? Because the grandparents are vulnerable, especially to the COVID. But then the other possibilities, and I worked in West Virginia for a while where you see something kind of similar with the opioid, except it's the parents who are using opioids, and then the kids who are left without caregivers. So these are the questions these are the things we need to weigh.
Thank you, Dr. Gurley. We are actually at time. I would just want to thank you very much. This is a super talk and discussion, and a lot of promise here, a lot of more work to be done, and appreciate your candor in speaking to us about this. I invite folks to continue the conversation with Dr. Gurley over email. Before we go to things, next week, we will meet again online. Together with CDHA, CDE is hosting Dr. Monica Alexander, who's a demographer by training and holds joint positions in statistical sciences and sociology at the University of Toronto. And she'll be sharing her work on Bayesian models and demographic research, which is part of her larger focus on advancing measurement of disparities in health and demographic outcomes. So do come back. I look forward to seeing you next week. And before we depart ways here for today, please join me in thanking Dr. Gurley for a revealing and actually very meaningful presentation today. Thank you so much.